Behind the Mask, the podcast. Behind the Mask. Behind the Mask. With Dr. William, PhD genius. Behind the Mask, Dr. William. The more you know, the better you do. Behind the Mask, the podcast.
Hey guys, welcome to another episode of Behind the Mask, the podcast, where you'll learn everything you need to know before deciding on plastic surgery, because the more you know, the better you look. All right, guys, we interrupt this broadcast to bring you our winner from our last episode's OG Wheel $250 giveaway. So if you see your name on the screen, then check your DMs because we'll be contacting you soon to get your winnings. Thanks, guys. We'll see you next time on Behind the Mask. My name is Gabby Allen, and I am here with board-certified plastic surgeon here in Miami, your favorite and my favorite most of the time, Dr. William.
Thanks, Gabby, for that warm introduction.
Always.
Truthful introduction.
Mm-hmm. Always telling the truth. Honest gal. Well, today we are talking about breast reduction. We have talked about breast augmentations. We haven't covered this yet.
Yes.
So we're going to go through it pretty quickly, get you guys all the information you need. And let's just start with, what is a breast reduction?
Yeah, so breast reduction is, believe it or not, just as it sounds, making the breast smaller.
Perfect. Thanks for tuning in. That's the whole episode.
Okay.
Done.
But no, the reason that it's important to know that is because that I think sometimes people have a breast reduction maybe for other reasons. They think that that's going to be a lift or something. So we'll go through and kind of talk about that. But if your breasts are too large, they're bothering you, exercise, wearing clothes, don't feel comfortable, feel that people are looking at you or gawking at you, feel self-conscious, all of those are reasons that patients undergo breast reduction. But it's principally designed to make the breast smaller.
Okay.
And when we do that, we always lift the breast at the same time. And I do hear people saying they want a lift and reduction, but a reduction comes with a lift.
Okay, so it doesn't have to be clarified like reduction and lift. It just kind of goes without.
Yeah, it's a breast reduction, and we're lifting the breast, and at the same time we're lifting it, we're making the breast smaller by removing skin, fat, and breast tissue.
And who is a good candidate for
So,
this?
the kind of the indications for it are, women that have breasts that they just feel are just too large for them.
Okay.
I would say the typical person that has a breast reduction, the story usually goes is their breast developed early.
Okay.
They were very large, sometimes, young ages like, 10, 11, 12. Their breasts come in and they're the girls that are in middle school and whatnot, and their breasts are just huge, and it affects them in so many ways, and in terms of they feel uncomfortable.
Yeah.
They're the girl in the class with the big boobs, and most of the other girls at that time are completely flat.
Yeah.
And so they really get, and I can even remember from my elementary school, a person who had, really big breasts. And
Yeah.
I mean, if I think of her name, that's what I think of. She was, as young boys, we kind of always giggled about it, and you don't appreciate it obviously when you're a young boy. What she might be going through.
Yeah.
You just think like, oh, she has boobs. You're still trying to figure out what that really means anyway.
But
so
it affects that.
It affects
person
them, and
way
then they
different.
can go through all of the rest of their school and high school and college or working or whatever they're doing, and it's always a problem for them. And until, they figure out, hey, listen, I think I really do want to change things and get a breast reduction.
I feel
That's
like
sort of the typical story.
what I've heard most commonly from women who've had reductions is back pain.
Yeah, that's a whole nother host of kind of, it goes along with it some of the patients, if you were to see them, you just wouldn't believe how big their breasts are. It doesn't match their body at all.
Yeah.
They're always joke that, you got somebody else's boobs, they just don't fit their body in any way. And when you have breasts that are that big, then headaches, neck pain, back pain, bras that don't fit, and It really limits the type of things that they can do in terms of exercise or what.
Even clothes they are able to wear.
Clothes, yeah. So those are the main sort of factors that push somebody to come in and say, hey, I'd like my breast to be made smaller.
Okay. Now, can you explain the difference between breast augmentation, breast lift with implants, without, and a reduction? Because you mentioned reduction with the lift, but what if there's no reduction, but you wanting the lift? Kind of break that down.
So there's the way I like to look at it is, it's almost sort of two groups. One is just a straight breast augmentation. So those are patients with low volume of their breasts, no droop, and they really don't have enough tissue to droop.
Okay.
And so they get a breast augmentation, they get an implant.
Yes.
That's sort of a separate category. And then for all the other types of breast surgeries, it's kind of the same operation. So let's say somebody comes in, their breasts are too big, they'll get a breast reduction. So that's a lift, and we're removing volume. If somebody comes in, they're happy with the volume of their breasts, they're not too big, they're not too small, but they're droopy, then we just do a lift. So it's the same as a reduction, it's a lift, but instead of taking out volume, we're just leaving the volume and just doing a lift.
Okay.
And then if somebody comes in and they have droopy breasts, but they want their breasts to be bigger, they're empty, they don't have a lot of volume, they have the droop, we do the lift, and we add an implant.
Okay.
So it's always really the same concept that we're going to lift the breast. With a reduction, we make it smaller. If you're happy with your breast, we just do a straight lift. The volume stays the same. If you want your breast bigger, we do the lift, and we add an implant.
Okay. And then how does a patient, or how do you see and determine, okay, this person needs a reduction or a lift? Has there ever been a moment where you're like, hey, you actually might benefit from this, and they don't maybe even realize it?
Yeah, so that's something that actually does come up quite a bit. And there's two groups of patients in that sort of scenario that you created. So patients that come in, they have really big breasts. If they want them smaller, then that's easy. They go into the reduction category. And other patients kind of come in and they're not really sure what to do. And if they really do have a lot of volume, then I direct them towards a breast reduction.
Yeah.
If they're happy with their volume, I say, if you're wearing a bra, or you want your breasts bigger or smaller? I say, no, I don't want them bigger. I don't want them smaller. They just have a lift.
Got it.
One area that does get confusing is when people have a very wide breast. And so usually what you'll see is patients that have large breasts that are candidates for breast reduction, they will typically have a wide breast.
Okay.
And the way I kind of explain it is if you have two different glasses, or just say like a container kind of, pitcher or something. And if your container is wide, it's big circumference versus a narrow one. And you can imagine if the breasts were sort of being made this way and you were just pouring water, well, that person with the wider is going to take a lot more water to fill it to the same level as somebody who's got a narrow. And usually those patients that have wide breasts have big breasts, and they will come in asking for a reduction.
Okay.
But where it can get tricky is patients that have that same wide breast, but they don't have as much volume. And so they would like to have a lift with an implant. The trouble is they don't look good with an implant.
Why?
If you imagine this, if you're a patient that has a very wide butt and you want a perky butt, it's probably not possible to get you a perky butt. You have to have more of a narrow butt in order to be able to get more perkiness to that butt. And it's the same thing with the breast. If you use an implant in somebody that has a wide breast, you have to select an implant that fits the breast. It's going to be a huge implant. And it just doesn't look good.
Okay.
Implants are meant for women with narrow, small breasts.
Oh, that's good to know.
And so that's when it gets tricky, and it comes up with this concept of patients want to have a reduction with an implant, but what they really want is they want a narrower breast. And so usually patients will come in, and as soon as I see their breast, I know that they're not a candidate for an implant because their breast is very wide. But when it's difficult to tell somebody you're not a candidate for something.
Sure.
They want to have bigger breasts. They want to have a look of an implant. And I know that they're not going to have that look after surgery with an implant if they have a wide breast. And the most common thing patients will do, it's almost like basically it's 100% of the time, patients will push from the side because their breasts are going into their armpit and past onto the side, towards the back. So their breast is really like this wide, but they'll take their hand and they'll push, and they're like, well, I just want this.
Yeah.
So they want a narrower breast, but you can't just cut the breast like that. You can't change the width of the breast, just like you can't move your eyeball. You can't change the width of the breast. And so when you have a very wide breast, it's too wide to support the implant, which is more narrow, and so the implant just drops. And so they want an implant so they can get the fullness in the upper part of the breast, but that's not the way it works. The implant drops.
Okay.
So they end up with a droopier, heavier breast. That's
is not
the
the look
exact
they're going for,
opposite that they want to have.
I imagine that's how you explain it, though.
Yeah, I mean, I show them photos,
Yeah.
and I say this is, I have a little talk prepared that kind of takes patients through, and I've seen a lot of patients in my career who have had an implant with a wide breast, and they don't like the look of their breast.
Yeah.
And they said that they were happier before surgery. I didn't do their surgery, but when I asked them, well, what were you expecting, to look like, they all go like this. And I said, that's where the problem is. Your breast was wide. You have an implant. You expected to get the fullness up top and have kind of a perkier breast. But when your breast is wide, it doesn't work that way.
Yeah. Okay.
So that's the only tricky part, I think, with all of this is for women that have a wide, emptier breast. We can do a lift.
Okay, that was going to be my next question. If you can't offer the implant, can a lift kind of serve that?
The lift can be a little tricky because if their breasts are empty, you're not really going to get very much fullness.
Okay.
So it's really not worth doing a lift, and then they're not a candidate for an implant.
Yeah.
And so patients will be like, well, am I stuck like this for the rest of my life?
Yeah.
And I don't like when people say that because it seems like it's an affliction or something.
Yeah, yeah.
But I do say, listen, there's just nothing that I can offer to help you.
Yeah.
And your best bet is really to stay with a bra and achieve the look that you want with a bra.
Yeah.
When you're not wearing a bra, you're not going to get the look that you achieve. But that's much better than going through the operation, get an implant, and being unhappy, and 2 or 3 years later you have surgery again by a different surgeon because you think, oh, that surgeon didn't do a very good job, so I'm going to go to a better surgeon. But it's not the surgeon.
Yeah.
It's the fact that the operation was not a good operation for you to begin with.
So that person would not be a good candidate for.
So they're just not a good candidate for
wide
an
breast.
implant.
Yeah.
Yeah.
Okay.
Now, if you have a wide breast and you have a big breast, which is most common, then that makes you a good candidate for breast reduction.
Which gives you the lift, anyways.
With the lift is what included. And so those patients are very, 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 very happy.
Okay. So volume, good. We want volume.
Yeah, because if you think about it, if your breasts have now become a burden and you're giving you headaches and back pain and neck pain, you can't exercise, you can't wear the clothes you want, you feel self-conscious, then having a breast reduction is just absolutely the best thing. Yeah. And that gets back to the point where it's all about your expectations before surgery. So not just having a realistic expectation, which obviously it's my job to tell patients what I think I can or cannot do, but it's wanting your breast to be smaller. Like if you go in and you're thinking, I'm going to get a breast reduction just because you want to have a small perky breast, it's really not going to be that way.
Okay.
It's primarily designed to make the breast smaller.
Okay.
Of course, we lift it. We make the breast look as good as we can.
Sure.
But when you get a breast reduction, you have a wider breast. That's the whole reason why you have a large breast. So when you get a breast reduction, you're not going to have that narrow, perky breast. It'll be much better.
Yeah.
The bras will fit you better. The nipple and the areola are smaller. They're up higher on your chest. The shape is better. There's more volume in the upper part. There's a lot of really good things that come with having a breast reduction. It's why it's such a satisfied group of patients. But you have to have it for the right reason.
Yeah, having realistic expectations, especially for your body type.
Yeah, if you go into a hair salon and you want a haircut and they're like, well, we don't have any stylist available for you, but we have a spa, you get a manicure. Oh, okay, I'll get a manicure, but that's not the real reason you came there. So you're not going to be as happy. So if you're coming in just to get a small, perky breast, you're probably not going to be happy.
Yeah.
If you're coming in because your breasts are a pain for you in so many ways, then yes, you're going to be happy.
Yeah.
And sometimes we take off, 5, 6, I think the larger patients are even more, 7, 8 pounds.
Wow.
That come off from a breast.
Do these patients have like
reductions.
instant once you wake up from the pain of the surgery, like instant relief then?
Yeah, well, this is maybe a poor analogy, but if you see people wearing a backpack that's hanging way down, you take those front 2 straps and you pull them up, you instantly feel.
Yeah.
So it's almost like your backpack's lifting you up now. It's like, woo, I'm lighter. But it's like that. I feel sorry for some of these patients, as I'm just like, how on earth did you get to be 36 years old and carrying these around? It seems just such a burden. And I've had more than one patient, lift their breasts up and put them on the desk, and literally be like,
here you go.
You got to take care of these for me. I can't.
I'm leaving them here.
Yeah, I can't.
I'm walking away, and they're staying right here.
Yeah, and they do things. They put their arm underneath. They hold their breasts.
Yeah.
They'll wear 2 bras.
Yeah.
It can be really difficult, and I feel it feels good to be able to help someone like that.
My aunt had a breast reduction, and what a difference, like the back pain especially for her, and just night and day. Just happy, feel all positive.
Yeah, and the same thing happens too in those patients that really weren't candidates, and you remove their implant. They're very happy as well.
Yeah, because you're feeling better too.
It feels so much better.
So can you take us now through the technique of how you go about this, the reduction and the lift, kind of just the actual operation?
So there's remember, so everything is a lift. There are some technical differences that I don't want to really get bogged down into. There's multiple different styles of lift, and I employ different techniques if I'm doing just a lift versus an implant with a lift versus a breast reduction. But the same principles apply in that there's usually a scar that goes around the areola, down the center of the breast, and underneath on each side.
Okay.
And the so-called inverted T or anchor pattern. So that's usually common with all of those procedures. And with a reduction, the incision usually goes a lot longer. And because the breast keeps carrying out more towards the outside, towards the back. So that's where the incision has to be.
Okay.
And I'm always careful to tell patients, like, the incision will be much longer than you think it will be, because the breast goes much further than they realize their breast goes.
Yeah.
And the other important part is years ago, I never used to do liposuction during a breast reduction, with my breast reduction. I would just do the breast reduction, and then patients would come in and go, why did you put this here?
Yeah.
I'm like, I didn't put that there. That was there.
That was there, yeah.
But they never saw it before, because their breast was so big and hanging down. Once you bring their breast up and make it smaller, this tends to stand out. And so I go through in a lot of patients that I do breast reductions and lipo that area so that gets flatter. It helps to distinguish the breast from the lateral chest. It helps to, get rid of that area that patients weren't aware of before, but then become aware of.
Yeah.
And it also really helps the bra fit.
Okay.
So if you imagine the bra, when you've got that breast over there, it's usually more fat. The bra can't really stick as well to the side and be as supportive, so it really helps it to fit better.
Okay.
So I always lipo that area as well when I do a breast reduction, or most of the time if patients have some fat there.
Oh, okay. So now something that always comes to mind when I think about or even consider a breast augmentation, what about nipple sensitivity? Is that at risk of losing? That might be a myth kind of thing? I don't know if we've even touched on that, but I've heard that, so much. I don't even know if it's true, if that happens.
Yeah, oh no,
and it's something
for sure.
I'm afraid of,
Well, with any breast surgery, breast augmentation, lift, reduction, you can have a change to your nipple sensation. Either they become less sensitive or more sensitive.
Okay.
Usually both of those situations get better with time, although that can take a long time.
Is one more common than the other, or it just completely depends on the patient?
I would say everybody tends to get, most people tend to get some hypersensitivity
Really?
of their
Okay.
nipples. It's pretty common. And then, let me just say, I would say everybody gets some change to the sensitivity.
Okay.
That's usually temporary, but temporary can last over a year.
Oh, wow. Okay.
Yeah.
Okay.
So, or it can be permanent. And obviously at the beginning we don't know.
Sure.
It's not super common, but it definitely can happen. And I think that the thing that's interesting to know is, when I do a breast augmentation, I make the incision underneath the breast, in the crease. And I go in and put the implant in. Now, we're not disturbing the nerve. There's multiple nerves. Nerves come from the outside. Basically, they come from the nerves in your back, and then they they wrap around. They come from the spinal cord, and then they wrap around, and then they come and they go towards the nipple.
Yeah.
But they come from the outside. So you can make any incision around the areola, and it doesn't affect the sensation at all.
Wow.
Because the nerves are coming from below. And so that's kind of a widely held misconception.
Yeah.
Oh, I don't want any incision around my nipple because in my areola because I don't want to lose sensation.
Yeah.
But it's not. You can have a breast augmentation with just an incision underneath. The implant goes in. The implant can put pressure on that nerve, and you can have problems with sensation.
Okay.
Without having any incision around your areola. You can have a breast lift or breast reduction, and obviously you have those incisions we talked about, an anchor. So you have an incision around the areola, and you can have no problems with sensation.
Wow.
So nerves are always just very tricky. They have their own sort of agenda, their own mind is what they want to do. One of my old professors, he had, when he was younger, an orbital floor fracture. So the bottom of his that supports the eye socket, sort of where your cheek got injured. And there's a nerve that comes right here that gives supply to your cheek.
Yeah.
And that was injured during his. And he said 12 years later, he got sensation back. Oh. So there are crazy stories about nerve regeneration.
12 years.
And
it's nothing. Okay.
And sensation. So we don't really have that much control over it. And it's just something we advise patients. It's possible to have. Could be temporary or permanent. It's not super common, so I don't think it doesn't usually come up as a reason why patients don't have surgery. But it's something to be aware of and just kind of know that it's there. I do think one thing that's very important to help is prevent the hypersensitivity, which can be really uncomfortable.
Yeah.
Is to touch a nipple in the areola after surgery.
Yeah, we've talked about touch therapy. So I was going to go into recovery after that or next.
Touch therapy.
So how
is really
does
important.
that?
It's just, it's very simple, and yet it's something that if you have an incision that goes around the areola, people are hesitant to touch that area. But they're not going to damage anything, and they can even do it through the bra right away.
Oh.
I mean, I don't think people do it in recovery, but I tell patients you could do it in recovery, in the recovery room, literally, when you're wearing your bra, and just to touch.
Yeah.
Just to give some feedback.
Does like light massaging help with blood supply and kind of like we've talked about massages
Yeah,
with BBLs? Does it serves the same purpose?
A lot of the techniques that we employ in this regard, we don't necessarily know how they work. We just know that they work.
Yeah.
And so touch is just, I mean, I could talk all day about it because I think it's so important to give your nerves the normal sensation that they feel every day, and not to stop when you've had surgery and then you deny that sensation to your nipple and your areola, and then those nerves start to act up because they're not getting their normal attention. Yeah. So,
I can relate. I get it.
touching. Well, I'm not talking about that, but touching is just so important. Hard, soft, rough, something's really smooth, different
Material even.
different materials, different pressures. Anything you can do to vary the amount, the what that touch sensation is going to be helpful.
And what is the recovery process like as far as time, for example?
So recovery from breast surgery is really pretty easy. It's not particularly painful operation. You would think that, if you have a breast reduction, it's a big scar, goes around the areola down underneath. That must hurt a lot. It really doesn't. When you make an incision, your knife goes through and you cut the nerves in the skin, so that immediately becomes numb.
Sure.
And so right around your incision, it's not painful. So the concept of have all these big incisions that's going to really hurt and be uncomfortable is not really true. That doesn't really hurt very much. And I think with breast reduction, in particular, patients don't really complain about a lot of pain.
Okay.
The biggest problem that we see with having a breast reduction or having a breast lift is something called triple point healing.
Okay.
And so what that is we're talking about that bottom part of that T, that inverted T, the anchor. You have a vertical line and then you have a horizontal line, incisions. And so the blood supply to that little area, that little intersection of those, the vertical and the horizontal line, the blood supply has been cut off from all directions. So it's very weak blood supply. And that skin there can die. And you can get like a little opening. It could be the size of a quarter.
Oof.
And it can cause a lot of anxiety for patients. They think they have an infection or that this is not going to heal. They're going to stay like this. It doesn't. It happens. It's not an infection. It's a problem with the blood supply. So I like to really be careful to tell patients to expect that, because it doesn't happen to everyone, of course, but if you expect it and realize it beforehand, it's much easier to deal with. And I think if you had to tell somebody one thing before surgery, before breast reduction, that's what I would tell them.
Okay.
Hey, you may have a problem. Don't worry. It's going to heal. It'll be fine. But just know that that's there. And all we do to treat it is soap and water and gauze.
Okay.
Occasionally, if it gets bigger, and it really is, it looks like sometimes they can kind of stall in terms of the healing.
Yeah.
Then I will use some PRP, which is a platelet-rich plasma. So basically your own blood, we remove it from you, spin it down in a centrifuge. That separates the components of the blood. We don't want the red blood cells. They're not doing any good. We just take the plasma, which has got the platelets. And platelets are these little repositories of growth, basically things that help you heal, growth factors, and all these different things. It's like little magic. I'm a huge believer in PRP. And we take that and we'll inject it into that area, and that'll just kind of stimulate that wound to heal. But I only need to do that if it's kind of a bigger wound or it's not really going anywhere.
So the recovery for a breast reduction doesn't seem that different from any breast surgery? It seems like a pretty fast turnaround.
Yeah,
too.
it's not particularly painful.
Yeah.
As long as you're wearing your bra,
Mm-hmm.
you can get back to some regular activities.
Mm-hmm.
Really within a few days, if you feel comfortable.
Is there a
doing that.
specific type of bra or support? Like there's some that are padded, or you know what I mean? What is the preferred bra?
Yeah. So I don't know if you know or not, but I have a bra now, and it was, this is interesting stories. I had a patient. I had a person email me from Australia, and they said, I want to send you this bra. I want you to try this bra. And she has a good story. I mean, from a development part of the bra, but it's a bad personal journey she had to endure.
I see.
But she had breast cancer, and she went through, breast cancer reconstruction is a very difficult process to go through, period. There's a lot more complications with it than there is for somebody coming in for breast augmentation. So she had a very difficult time recovering. She had some flaps that failed. She had implants that failed. She had tissue expanders. I think she underwent 10 surgeries or something. It was a nightmare for her.
Jeez.
And she said that every time she went, I think she went through multiple, surgeries in different locations and whatnot. And she said every time she woke up, she had a different breast dressing on. And so she developed this breast dressing, which it's really good. Like, it's really, really good. As soon as I saw it, I'm like, yes.
Oh, wow.
I want to be part of this. And so we're distributing that now. And it's a dressing that really considered a dressing. So we put it on the operating room, and then it gets changed the next day. It's a sterile dressing, so it's clean, and it's absorbent, and it has some really good support for underneath the breast as well as above the breast. So it's a fantastic dressing, and we use that for the first 5 days, and then patients will go into a post-surgical bra.
Okay.
Which, again, is very supportive. And I usually have patients wear that for usually at least 2 months. And then they can transition into a sports bra.
Oh, okay.
Or, wait for this,
Okay.
they can wear an underwire bra.
Okay.
Why are you frowning?
Well, I didn't know. I feel like I've heard,
Botox
I
is
know
wearing off.
my Botox is wearing off. Oh no. Anyways, my question was, no, that's surprising. I feel, obviously I haven't had breast surgery before, but the women that I know that have, I've heard so many different things that that was an absolutely not. And then it was other women who had to hold up their breasts for so long right after.
Okay, so you're frowning, and I saw you frown, and I expected you to frown, and I kind of set you up for that.
Ugh,
Not
got
just
me.
for the Botox joke, but because that's a really widely held belief that you can't wear an underwire bra after surgery. I believe the opposite.
Okay.
I think it's fantastic to wear an underbra. I'm a proponent of it, and so I tell patients you can wear an underwire bra. I think it's good to wear an wire bra because of the importance of the inframammary fold. So a long time ago, when I used to do breast reconstruction, is really when it dawned on me and realized the importance of the inframammary fold and how it sets the entire breast up to look the way it does.
Sure.
So if you go way back in time and look at how women were treated with breast cancer, I know this is off topic from breast reduction, but it really kind of fits in. And so way back when, they were much, much, much more aggressive with treating breast cancer surgically. They thought it was a surgical disease and that you have to take every single thing off of a woman's chest. So they took the skin, the nipple, the areola, the whole breast,
Oh my gosh. Yeah.
the pectoralis major muscle. They took all the lymph nodes in the sternum, all the lymph nodes under the collarbone, all the lymph nodes in the armpit. And these patients had very bad lymphedema of their whole arm because they'd been stripped with all their lymph nodes, so patients would have huge arms and then have to wear these sleeves. It's very painful, debilitating, I mean, really horrible. And so it was very aggressive removing all of that. And as time has progressed, we realized, like, you don't have to take the pectoralis major muscle. That doesn't have any cancer in it. So you can leave the muscle behind. And then as time progressed, they just kept taking less and less and less and realizing, oh, if we just take the tumor and do radiation, that's actually the same as if we take the whole breast. So there was a lot of changes in development of treating breast cancer from a surgical point of view. And now what happens is for most patients that are candidates, they can do just a nipple-sparing mastectomy, meaning the nipple and the areola, all the skin envelope is still intact, and you just take the breast tissue out. And then the plastic surgeon can come in and just put an implant in and replace what was removed.
All at the same time?
Yeah.
Wow.
And that's a totally different topic, and it's called direct implant. But and I don't do any of that anymore. But what you learn, and when the general surgeons who removed the breast, and then we as plastic surgeons did the breast reconstruction, when the general surgeons first started off, because they were so aggressive to them, because they were trained to, you have to remove everything, they would very often, very frequently violate or disrupt the inframammary folds. And once you do that, you've lost that crease, which is really defining for the whole breast. You have to reconstruct that. We don't have to do that as much anymore, because the general surgeons have sort of developed with us, and knowing that, you don't need to do that. You can leave that intact. But during all the time where you do all that reconstruction of that fold, when you really realize, and this was part of my learning curve, when you don't get that right, the breast doesn't look good.
Okay.
So you have to get that absolutely perfect, that inframammary fold. And the same thing is with the breast augmentation, same things with the breast lift. And so helping to secure that fold, wearing an underwire bra, not right away, because I can put a little bit too much pressure on that area, but you can certainly wear that at the 3-week mark, and that helps that inframammary fold stay where you put it. And so I think that's totally fine to be wearing that type of bra. The other benefit that you get from wearing an underwire bra is just pressure on the scar.
Okay. Oh, okay.
And pressure works really well. I don't know if I ever told you the story that I had where I had a patient who I removed a lesion up on sort of her upper back, collarbone area. And, it was a skin cancer. And it was the scar was probably, I don't know, maybe an inch long or so. And it was so interesting, because half of the scar was covered with her bra strap and half was not. And if you looked like at a year, the part that was covered with her bra strap was flat, and you couldn't really even tell there was a scar there.
Wow.
And then immediately, where her bra strap wasn't making contact, was raised and lumpy.
Wow.
And so, we've known for years that pressure is really beneficial. It's why patients who have severe facial burns and they get facial reconstruction, they wear those hockey masks, like goalie masks, that are clear, but they're putting pressure on. And they get garments made for their hands and their arms that are really, really tight. Really pressure. So pressure is very beneficial for scar maturation and getting a good scar. So having that pressure from the underwire bra, I think is helpful from a scar point of view as well, and secures the fold.
Got it. Okay, now let's talk pregnancy.
Yes.
How long after can you have a breast reduction? If you have before, how does the breast reduction affect breastfeeding? Kind of how does pregnancy play into this?
Okay, that's a good question. So you would think that if you had a incision around your areola down underneath, reduce the breast, cut the breast, do all that, you wouldn't be able to breastfeed.
Right.
The answer is you actually can still breastfeed. All of the milk ducts and the nerves that are there that remain are still functioning.
Yeah.
So breastfeeding after a breast reduction is not impacted.
Okay.
And your question about how soon after pregnancy can you have a breast reduction? It's not really, the timeline doesn't start related to your delivery. It relates to when did you stop breastfeeding.
Okay.
So if somebody breastfed, let's say somebody did not breastfeed, then you could have a breast reduction 6 months after having your child.
Okay.
If you did breastfeed, then it's 6 months after the date that you stopped. So let's say if you had your child and you breastfed for 3 months,
Okay.
then you'd wait another 6 months. So it'd be
Got
total
it.
of 9 months from having your child. You'd be able to have a breast reduction. And the reason is that it takes a while for those ducts to dry up and the breast to
Which is what you're
stop
waiting for.
making milk. Yeah.
Got it.
You don't want, I've been in a situation where you've operated on patients and for whatever reason, the timing doesn't work out, and you're going through the breast, and there's like a lot of fluid around, and that just leads to, high risk of infection.
Okay.
And we want everything to be kind of withdrawn and small and healed again before we get back into that.
Got it. Okay. Now let's say you have a patient that wants a reduction and a BBL. Is this something that can be combined, or would you recommend one before the other?
Yeah, so I never do a breast reduction or breast lift with a BBL because the blood supply to the nipple and the areola is changed with those operations.
Okay.
And I don't want somebody putting pressure by laying on their tummy with their BBL afterwards.
Right.
Breast augmentation is fine to do with a BBL because you're not really changing the blood supply when you do a breast augmentation. You're really not disturbing the blood supply at all. You're just making an incision underneath, kind of going underneath and tucking the implant in. So it doesn't really affect the whole breast. Whereas when you do a lift or you do a reduction, you are cutting into the breast. You're decreasing the blood supply.
So it's a bigger procedure.
It's a bigger procedure, so we don't want pressure on that weaker blood supply to, it's like having a hose that you kind of stand on. If you're going to be laying on your tummy, that's like standing on a hose, putting pressure, and you're cutting down that water. And it's the same thing with the blood supply. So I don't combine a BBL with a breast reduction or with a breast lift. Breast aug, no problem.
And we've talked a lot about, obviously, the pre and post care. Is there anything specific or special or unique to the prep for a breast reduction that patients should know?
So certainly nothing that's going to make you bleed. So no anti-inflammatory drugs like Aleve, etc.
Okay.
No smoking for 1 month beforehand, because again, the main difference when we do a breast reduction is, compared to breast augmentation, is we're changing the blood supply. Smoking will decrease the blood supply. It constricts the blood vessels, the nicotine. So no chewing tobacco or oral vaping, none of that has nicotine in it for 4 weeks before and for 4 weeks after, because it can lead to a decrease in the blood supply, which can lead to loss of the nipple or loss of the areola.
Yeah, we don't want that.
No.
Okay, well, good to know. We're going to take a little break before we go into the post-op care, and let's take a question from social media.
Hey, TikTok, say what?
Yeah, it is from TikTok. All right. What is the youngest age someone can have a breast reduction? And what is the youngest patient you've given a breast reduction to? Or what was the age?
I don't remember off the top of my head exactly, but I would guess probably 16.
Oh, okay.
Yeah.
It's young, but I guess sometimes it's necessary.
Yeah, we usually like to wait until the women's breasts have finished developing.
Yeah.
And they're finished growing, and so that's usually by 16. And then the patient has to be of, mature enough that they can go through something like that at that young age. But I would say I'm always impressed with some of these young girls that come in, and they know what they want. They've seen it on YouTube. They've been following. They understand. They're well informed. And for all the reasons we talked about, they are unhappy with the size of their breasts. Their parents still have to give the permission, because you have to be 18 or older to sign your own consent. as an adult, but that's usually the range. I know there are surgeons who have done it younger, and there certainly are situations where there are other parts of women that will have really, 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 really big breasts that are abnormally large. And we can intervene earlier in those patients because they're going through so much difficulty. They have a higher risk of actually regrowing some breast tissue.
Really?
Yeah. I think that gets overstated in some patients. They will gain weight after surgery and they will say, oh, my breast came back. But that's really just more of a weight gain issue.
I see.
There are as a small group of patients with gigantic breasts, that's what we actually call them, and they can grow back. Most don't.
Not to the degree that it was before, but it does.
For some patients. It's not common, so I don't want to make it like a big point. But, you can operate in younger women who are just have more severe cases where it's very difficult for them to sort of carry out their usual activities.
Got it. Okay, so whenever it's absolutely necessary, and these women are obviously in a lot of discomfort, so that makes sense. Okay, let's go back to some post-op. Let's talk, we touched a little bit on scars. Let's talk on how pressure really helps with that, and how does that play into like keloids and just taking care of scars. What is the best way to treat scars after a reduction?
Yeah, I mean, and this is generally with most surgery, but I usually have patients begin scar massage at 3 weeks. The wounds are strong enough that they can be massaged. And so scar massage with a silicone base is absolutely the best way. Everyone should be doing that, and that should be happening for 2 minutes twice a day.
Oh, that doesn't seem... I would think it would be many more minutes than that.
Well, you try and keep it short because you want to be consistent. Okay. So if you're going to do it for 20 minutes a day, you're probably going to do it once a week. If you do it for 2 minutes twice a day, you're more likely going to be doing it every day. And the consistency of doing it every day is what's important, and it has to carry on for 12 months. Ooh. So it's a big commitment, so you can't make it your whole day. So 2 minutes firmly massaging. The other thing that's very helpful are any type of silicone strip that goes over the incision, and that can be placed inside the bra. It's a little bit similar to the pressure that we were talking about earlier. And so it can apply a little bit of pressure, and just having that silicone in contact with your skin, we don't know exactly how it works, but it does help. I mean, plastic surgeons, I guess we use silicone for like everything.
Well, if it works, right?
So, but that's really beneficial. And those are kind of the two main things to do with scars. Sun protection as well. You can get some areas that are hyperpigmented. Okay. I'm not good about wearing sunscreen on my arms, and I was in that little bicycle accident over a year ago. You can see how it's darker than the surrounding tissue. It's hyperpigmented. And so you could protect the incisions from becoming hyperpigmented from sun. Usually not that big of a deal with the breasts. They're not exposed like that. But that can help too in general terms. Those are the main things for scarring. As far as the other aftercare, it's staying in the bra. And then just going about your regular activity with touching and doing all of those types of things. And that just helps you recover. But the recovery is not long from a breast reduction. It's patients usually can go back to work in a few days after that.
That's crazy.
Yeah.
Okay, can you talk about scar spread out and scar revision?
Sure. So scar spreading is, it can happen in breast reduction. It can happen in anything that we do. The higher the area of skin tension, the more likely the scar is to spread. Okay. So the things that usually are the tightest are a tummy tuck, and so the scar can spread from that. You'll of all the scars, the one most likely to spread is a tummy tuck. Okay. In terms of what we do. Things on the back, those scars tend to spread. So you'll see patients that have had like a small little mole removed, and yet they've got a scar that looks like, they took out a big tumor or something. So it'll spread because the back is a high tension area.
Okay.
Breast is not really a high tension area, and so we typically don't get a lot of scar spreading. In the breast, you can have some around the areola. I find that I really don't have as much anymore as I used to because I use a little bit different suture technique now that Dr. Hammond, who's a breast surgeon in Michigan, pioneered, and it's a really good way to kind of absorb and relieve the tension on the nipple and the areola. Okay. But even still, everyone can potentially everyone's skin is different. They can have some spreading of that scar. We can do a revision, although I will tell you that scar revisions can be very disappointing because
So maybe it's better to not.
It's better to massage.
Oh, okay.
It really is better to massage, and I think that's how you really get the best scars.
Mm-hmm.
With keloids are really a whole nother topic for another podcast. There's quite a bit going on in keloids now. Yeah. Actually, we were kind of stuck for years.
Yeah.
As to, there really weren't a lot of great therapies. There are some better therapies that are out there now.
Yeah.
But if somebody has keloids and they've keloided in the past, or they have a family history of keloids, they're more likely to develop a keloid, and there's not too much we can do to prevent it at the time of surgery. Mm-hmm. I will say that it is less common to happen in the breast than it is in other areas.
Good to know.
But I certainly have had some patients with keloids, and it can be pretty devastating when you have a keloid that goes around your areola, down the middle of your breast, and under on both sides. Mm-hmm. Again, fortunately, it's not common. I mean, I really can only think of 2 patients off the top of my head out of, a lot of breast reductions that I've done over the time that had that problem. But it's that type of thing where, yes, it's not common. So if someone tells you, it's a 1% chance or 0.5% chance or whatever it is, it's if it happens to you, it's a 100% chance.
Exactly.
Really,
like those odds.
So that's difficult. Usually, what we do with keloids, and as I said, there's some new therapy. So there's some chemotherapy now that we can inject, and
really, wow.
Yeah. So there's some other things that we can do to help. To flatten them out and
pressure in that, like just continuing massaging,
pressure, massage, silicone, those are all steroids, chemotherapy, and but it's radiation therapy can help as well. So it's kind of a multi. Whenever you realize in medicine pretty early, and I guess this is just in life in general, if there's not really one good way of doing something, it's really because there isn't just one good way of nothing works perfectly. Yeah. And so with a lot of these things that are problematic that we don't have like one good solution for, we try, multiple different things, and different things work differently in different patients. So there's some trial and error that goes on there. And I usually start small with treating a keloid after a breast reduction, maybe just on the corner and the outside to see how that reacts to your therapy before going ahead. Because some of the steroid or the chemotherapy, they can produce a lot of hypopigmentation, so they can whiten the area. And sometimes it's like the cure can be worse than the disease. If you have a relatively minor keloid, and then now you've got like big white area, that, is the trade worth it? So I will usually leave that up to the patient, and we'll start with a small little area on the outside. We'll treat that. If that looks okay and they're happy, it's like, would you like the rest of your scar to look like that? Would you be, or you want to make a trade, you want to trade your current scar for this. And if patient's like, I don't want to come back to the office all the time. I don't want to go through that. I'm not really thrilled with how that looks. Well, you haven't treated the whole scar, so it's just a small little area. Yeah. And other patients will be like, that's way better than what I have. Please, by all means, treat my whole scar because it itches, it hurts. And if you can get rid of the things that are causing pain or discomfort, I mean, aside from the way it looks, I mean, you're already ahead of the game. Yeah. So sometimes patients are willing to make that trade.
So let me ask you, I had a partial thyroidectomy in 2010. I had keloids really, really, really bad. It took about, 2 or 3 years for them to fully go away. They offered me the steroid injections, but I said, no more needles to my throat. I'm all set. No, thanks. It's fine. I didn't have any pain or discomfort. It just was cosmetically not, it was just raised
Yeah.
and red. Would that mean that, if I were to have a breast surgery that I'm more prone to get keloids because I did from that one?
Okay, so you didn't get a keloid.
Oh, what did I have then?
You had a hypertrophic scar.
Oh, okay.
Keloids tend not to go away.
Oh,
So
look at that. We're learning. I'm learning.
You most likely had what's called a hypertrophic scar, which
Okay.
is a keloid is actually when you form new scar in the areas that were not involved with the surgery. So if you have a hypertrophic scar, it's in the line of the incision.
Okay. Yeah.
And so your incision becomes red and raised and really looks angry. And so that usually with time and massage, you can speed it up with steroids, but that will usually resolve. If it doesn't, that is somebody that can have a scar revision.
Oh, okay.
If you have a keloid, the disease, it's a disease, and it extends beyond the scar. So you start forming scar where you never even had any surgery. It's just next to it, and you've basically, that incision is mad and angry, and then the cells next door are like, yeah, we don't like that either, and they start making scar tissue. And it's not the neck is. This is interesting because the neck is really not a high tension scar area. The breasts are not a high tension scar area, but this center part of your chest is.
Yeah.
And so they tend to things tend to heal not very well in this chest area. And when you get into the thyroid, you can start getting into that little area that doesn't scar as nicely as a little bit higher up on the neck.
Yeah.
But that doesn't mean your breast will be that way.
Okay.
Because this is a very high tension area.
Okay.
And I've done, I really don't do it anymore, but I've done countless operations, breast augmentations, where you make an incision for the breast, do the implants, that scar is perfect, and then they have something in the central part they're not happy with. So the patient's like, hey, while I'm there in the sleep, can you just take this little mole off, And you get a terrible scar here because of this high tension area in the center of the chest, and the breast is totally fine.
So you can't really determine how the scarring will go on your breast based off of how you've developed and healed from scarring in other parts of your body necessarily.
If you have a keloid anywhere, anytime you're going to use a knife on the skin, you're at higher risk of developing a keloid than if somebody didn't have a history of keloid on their body somewhere else. But having a keloid at the back of your neck or on your shoulder is not necessarily 100% chance you're going to have it on your breast.
Okay, got it. Now, what about flying? Does the pressure affect the pressure here? How does pressure work in that area?
It doesn't
Under
affect
pressure.
Doesn't affect it at all.
How soon after can women fly?
If somebody's flying in from out of town for a breast reduction, then I think it's safe to go home 3 or 4 days later.
Oh, wow. Okay,
Yeah.
so very quickly.
No, the main thing with breast reduction is you want to check and make sure there's no hematoma, so they're not bleeding after surgery. There's always a risk after having surgery to have a hematoma.
Very important.
And you want to make sure that the blood supply to the nipple and the areola is still intact. And so once, we evaluate patients for that during the first couple of days, they kind of get out of that window where those are going to be issues anymore, and then it's safe to travel.
Okay. And then how do you ever have to, or how often or how common is it after someone has a breast reduction that you have to go back and kind of redo anything, add implants, do another lift? Like, how is there ever a follow-up to reductions?
Yeah, so the reoperation rate after breast reduction, I would say, is pretty small.
Okay.
It's pretty low because patients are usually happy with getting rid of the volume that they have that was causing them all the problems. Of course, the breasts do droop again. We don't stop time. We just sort of reset it, or gravity.
Yeah.
And but it's not common to sort of have multiple breast reductions, and it's also difficult from a blood supply point of view. It's more dangerous to you can have more likely a chance of losing your nipple or your areola if you're doing a repeat. So it's not particularly common to do that. And then you mentioned implant after breast reduction, and that's usually not possible because the patients had the reduction because their breasts were wide.
Right.
So they're not candidates. There are some patients that do have a narrow enough breast to
That it works.
make them a candidate. And I can think of actually one of my wife's college friends who had a reduction during college, and then really lost all the volume after having kids and everything else, and she ended up getting an implant. But it's not particularly common, just because patients who undergo breast reductions usually have wide breasts and they're not good candidates for an implant. And it can kind of recreate some of the original problems that patients had at the beginning. So.
Yeah, we don't want that. Well, before we jump to the wheel, any other tips or things patients should know before having a breast reduction?
Two things. So one is a mammogram.
Yes.
And so it just depends on the age of a patient. We usually follow the guidelines.
Because what if they're young?
And our guidelines now, and they've varied over the years, but it's usually if you're close to 40, we'll get a mammogram beforehand, and then 6 months after your surgery, you get a new baseline. One of the real advantages of having a mammogram is to have a baseline. So you see something on the mammogram, you're like, it doesn't look bad, but not enough to warrant doing a biopsy, but let's keep an eye on it. So you have to have something, then you see it again in 6 months or a year, whenever.
See how it's developed.
And see how it goes. And so that's really one of the things. So having, if you're getting close to 40, we usually get a mammogram, and then 6 months later get another mammogram. Something that does come up quite often are breast cysts.
Okay.
And so patients are like, well, I have some cysts. Can you take them out while I'm there? And cysts are benign, so we wouldn't take them out while we're there just for we don't take things out that are benign.
Yeah.
And so, we like if you come in and you have a freckle or mole, you're like, I want this removed. And if it doesn't look bad, we don't take it out. So, but that's not the only reason we don't take out breast cysts. The other reason is because they're like a needle in a haystack. I mean, cysts are small and they're buried in between. And a lot of times, some women will have very cystic breasts naturally. So when we're going through and we're cutting through the breast tissue, you'll get all this cyst fluid pouring out.
Sounds like a mess.
Well, it's just, it's not that big of a deal, but it's just, you can't go in and remove a cyst. And a lot of cysts get removed anyway, just because that tissue is coming out. And then the other thing that's important to know is having a breast reduction decreases your chance of getting breast cancer, because we're removing breast tissue. So that tissue is not there to become transformed into malignancy. So there is a
positive
reduction.
There too.
Reduction in chance of developing future breast cancer by removing that breast tissue.
Do women who have a history of breast cancer, does that affect their candidacy for reduction?
That's a really good question. So I would say it can. So if somebody has a mastectomy, so the breasts are removed, obviously they don't need a breast reduction. There's no more breast. But for women that have had a lumpectomy, okay, so they just removed the core of tissue where that cancer was, and then they get radiation, because if you do a lumpectomy, just remove that and irradiate the breast, it's the same in terms of survival as removing the whole breast. So radiation and lumpectomy is equivalent to removing the whole breast. So in those patients that are candidates, they can have a lumpectomy and radiation. But so they'll essentially have a breast that's unchanged, because it's not a huge amount of tissue comes out with a lumpectomy.
Yeah.
But the radiation can kind of shrink the breast, and so their opposite breast might need a reduction for symmetry purposes.
Wow. Okay.
And so that's a symmetrizing operation. And that's usually done by surgeons, plastic surgeons that do breast reconstruction.
Mm-hmm.
And so someone will come in. And interestingly enough, the insurance will pay for that.
Oh, good.
So it's been like for 25 years now, there's a law that if your insurance carrier covers your mastectomy,
Mm-hmm.
then they also cover any reconstruction of your breast.
As
and
they should.
As they should, and any surgery required on the opposite, non-treated breast
Mm-hmm.
for symmetry. It's difficult to go through and do a breast reduction if somebody's had radiation therapy,
Okay.
because the radiation really just messes with the blood supply.
Sure.
And so they can have a lot of problems with that.
Okay.
So if someone's had usually, lumpectomy and radiation therapy, we steer clear in terms
Yeah.
of operating on that breast.
Good to know. Well, that has been all the information about a breast reduction. And if you think you're a good candidate, then hopefully we answered all of your questions. Okay, it is time for the OG wheel. But first,
Yeah.
it's the holiday season. I think
Yes.
we should get a little festive.
Okay.
Yeah, let's get into the spirit. It's snowing.
It's festive
It's
in
snowing
here.
in Florida. You know, I've never
actually chilly.
seen snow in real life, ever.
Oh, you never have?
Never.
Oh,
I'm on my
from
way
Canada,
to 30.
so
Well,
I can
need
tell you,
to-
it's
I told my
overrated.
list. Well, that's everybody says that. Oh, the snow is a little. So
Well, real snow is not toxic, but this might be.
everybody says that, and I think it's so easy to say it's overrated when you've experienced
Yes.
it. And I don't want to live in it. I just want to snow angel and then get out of there.
Well, no, it snows great. We're going someplace cold for Christmas, so going to Norway for Christmas.
I am going nowhere. Oh, to Norway.
Yeah. So it's going to be cold. It's way up there. It's way further north. You know where the
Gorgeous.
Edmonton Oilers play?
Yeah.
It's very far north.
They just played here the other day.
It's way further north than
That's
that.
fun. That's
Yeah.
Norway's
It's
beautiful.
near the Arctic Circle.
Well, that's my list. Oh, look who's here.
All
we
right,
go.
got the OG wheel.
And our BB elf.
Ah, the little elf came in. Whoa. He showed up.
What is he doing here?
I don't know. Sit on my water.
Does he have a name? You didn't like mine, so let's see what you got.
What is your name?
I said the BB elf.
Oh, yeah, BB Elf. That's good. I'll stay with your name. I like it.
Okay. Okay. Thank you for your support now, because
yeah,
you didn't
you're
love
welcome.
it before. Well, if you have a name for our elf, drop it in the comments, and Dr. William can pick his favorite.
Okay.
And then I'll
do it.
disagree with it. Perfect. Okay, time for the wheel. Here we go. What do we want today? TikTok? Maybe. Beauty pageant questions.
Oh, beauty pageant
You ever
questions.
look at someone and
I like
wonder
these.
what is going on inside their head?
It's here. Thank you so much. Here we go. It's time. Ooh. Mix it up real good. Okay. Here we go. Oh, it's a long one. Okay. Ready? Mm-hmm. Social media allows us to share every aspect of our lives, but it can also cause us to be hyper aware of how we measure up to other people. Do you feel that social media is ultimately positive or negative for our self-image?
For your self-image.
Or how we
Night is-
compare to other people, how we see ourselves in comparison to others.
Well, I think social media is wonderful.
Mm-hmm.
But like everything in life, there's bad things about social media. Definitely, I think it's good from an educational point of view.
Mm-hmm.
I educate a lot on social media. I look to social media to learn things.
Mm-hmm.
I am now like my kids, where instead of Google searching, I actually can search Instagram,
TikTok.
and TikTok,
Yeah.
and you find out a lot
So
of
easy.
lot of good information. And then with all of that good information and goodness, then comes the bad part. And I'm not an expert in any of this, but obviously, self-image of young people can be tainted by this.
Yeah.
So I don't know what the answer is, but I'm going to say it's good with the proviso that,
Can also be bad.
is given. I think that's a really good beauty pageant answer, to be honest.
I
with you.
do too.
I think it's good and bad. So my answer is yes and no.
Okay, fantastic.
Let's
we're
see what
going
the
with
real
we're going
answer
with
is.
both. Let's see how your answer measures up.
Social media allows us to share every aspect of our lives, but it can also cause us to be hyper aware of how we measure up to others. Do you feel that social media is ultimately positive or negative?
With social media, I believe it has given us so much power in this world. But with great power comes great responsibility. And I've seen
like a
both
cliche
ends of
like
social
that.
media. For
powerful.
me, it has been one of the
It
most
got me.
empowering
I have to be honest.
experiences because I've met so many empowered women. But at the same time, I've also been a victim of cyberbullying, like many of the contestants with me standing on the stage. Social media is, again, a privilege. It's something that you have to be careful of. You can't just say anything just because you're anonymous. And once we realize that, that's when we can truly live in a better world for everyone. Thank you.
That's a pretty strong answer.
That is. I agree.
Sounds like she had rehearsed it.
Yes, it does. Well, I will give you know what? Great answer.
And you just
That
popped these
counts.
on me.
Yeah, I did.
Yeah.
Like that. But you gave a great answer. I'd give you the crown.
Oh,
Why not?
yeah.
And I'd only give you good, positive comments
Oh.
on social media.
Thank you, Gabby.
Yeah. Ignore the trolls. Don't be anonymous. But thank you for joining us on another episode of Behind the Mask. Hope we answered all of your questions about breast reductions. But if we didn't, please comment, ask them. We will circle back and get you the answers. And don't forget to like, comment, subscribe, listen on Spotify, Apple, YouTube. Am I leaving any out? No, I don't think so. Probably not. I'm Gabby Allen. This is Dr. William. Thank you. And we
Thanks,
will see
Gabby.
you. Oh, and happy holidays. And we'll
Yeah,
see you
happy
guys
holidays.
very soon.
Behind the Mask, the podcast. Behind the Mask. With Dr. William, PhD genius. Behind the mask, mask, mask. The more you know, the better you do. Behind the Mask, the podcast.